So as I mentioned earlier, there may be situations where you're administering 2 through 4 IM injections. There might be a sub-Q thrown in there, especially when you're doing childhood immunizations or travel immunizations for adults. That means you're going to have multiple injection sites. So with frequent injections, things that you're going to be doing on a regular basis, and by frequent I would say probably on a weekly basis, you want to rotate the injection sites. There are some folks who come in for injections every month or every 6 weeks. That's more likely to be hormone replacement therapy or testosterone or birth control. With those situations, every 30 days, you can rotate sites, but it's not such a consideration. But if it's happening daily or on a weekly basis, then consider rotating sites. If you're administering multiple vaccines, you want to administer each at a different muscle site if possible, or you want to get enough space between them so you can differentiate them. For infants and younger children, if more than 2 vaccines are injected into a single limb, the thigh is the preferred site because of the greater muscle mass, and injections should be separated by 1 to 2 inches. So in case there's a localized reaction, you can see it. It's also important when you chart, if you're doing multiple injections, you would want to say, let's say you're doing 2, we'll take the scenario, you're doing 2 injections into the vastus lateralis of a child. So you should probably indicate it, let's say you gave MMR in the superior aspect of the vastus lateralis. So I would say, injection superior thigh, and let's say you did varicella in the lower. That's just an example. Let's say DTaP instead. So you DTaP lower than that, then I would say that's lower vastus lateralis or inferior vastus lateralis. This way, if you've charted it like that, you've noted which injection went in which site. If there's a localized reaction, we'll know which medication the patient's reacting to. So that's important. For older children and adults, the deltoid can be used for more than 1 IM and often is. Once again, separate by 1 to 2 inches. And once again, you want to say this is, medication X was superior deltoid, medication Y was inferior deltoid, or posterior anterior, however you're going to separate those. Once again, if there's a reaction and they're more than 1 to 2 inches apart, you'll be able to see the reaction. And if you know which medication was placed in which portion of that muscle, you'll be able to understand which medication they're reacting to. Vaccines that are most reactive should be administered in different limbs if possible. Combo vaccines reduce the number of injections. I mentioned that earlier. There'll be times when you're doing especially childhood immunizations, so there might be 3 or 4 vaccines bonded into one injection. It'll be a large volume, but only 1 injection procedure, which makes things easier for you. And as I mentioned already, document the location of all injection sites in the patient's medical record. If you didn't document it, it means what? It never happened. Exactly. So, patients with bleeding disorders, or if they're taking anticoagulants, which are another word for blood thinners, they may develop hematomas easier during an IM injection. IM vaccine should only be considered if the patient's bleeding risk is low, and if a physician determines that the vaccine can be administered IM with reasonable safety. So this is where the doctor's order is so very important. Always remember, it doesn't matter what the patient says. If you do not have a doctor's order, you may not administer that medication. So always make sure you have a doctor's order and that it's a clear order and you understand what they're asking you. In the case of a patient who is taking blood thinners or has a bleeding disorder, you should make them aware they may see a hematoma or a bruising at that site. You should try to use the smallest possible gauge you can get by with. And once again, that 25-26 gauge is pretty good. Apply firm pressure to the site for 2 minutes after injection. So that's after the needle's been removed, pressure down on the site. And you may or may not do this depending on protocol in the clinic you're at. Do not rub and massage the site. That's never a good situation for any injection, I found. Sometimes patients will rub the site. That's their choice. It's their body. I've seen MAs do it, and patients have various reactions to it. Some see it as comforting. Some see it as irritating. So it's best just to deliver the injection and leave it at that. And don't, by the way, you'll see this sometimes in practice. Sometimes people will take an alcohol pad and then wipe the injection site when they're done. Not recommended. It's going to cause a lot of stinging in that area, and it really doesn't serve much purpose. So you will see this in practice sometimes. If you're asked by a doctor or by your supervisor to do this, or you're ordered to do it, then of course follow the order. But as a general rule, I wouldn't develop that habit. It's usually doesn't really lead to anything. We want to be aware of latex allergies, so look in the patient's chart. If they have reported allergies, it should be on the allergy list, which is usually located with the med list. Administering a vaccine supplied in a vial or syringe that contains latex could be administered to an individual with a history, or should not be administered to an individual with a history of severe anaphylactic reaction. Well, that kind of goes without saying. If it says in the chart that latex causes anaphylaxis, yeah, you definitely don't want to administer it. You don't want to touch them with latex gloves either. If a doctor says the benefit of the vaccine outweighs the risk and the patient agrees, then that's a different story. Latex can be a local or contact sensitivity. It's not a contraindication to the vaccine. So latex allergies are about the actual material of latex itself. Maybe some of you have that allergy or you've seen it in patients. And I'll honestly say in modern medicine, we use very little latex anymore, but it still does pop up. Most of our gloves are non-latex and so on and so forth. So be aware of latex allergies and certainly want to respect them. If your patient says, hey, I really don't feel well, or I feel lightheaded whenever I get injections, that kind of thing, syncope, right? Fainting is going to be the risk. We never want our patients to faint when they're standing, because if they do and fall and hit their head, we've created a new liability for ourselves and for our clinic. I know in radiology and radiography, we have to be very careful about this, and we also have to be very careful in medical assisting. So fainting may occur. If the patient falls incorrectly, they may be injured. It's not common. It's not an allergic reaction. It's a form of shock, as a matter of fact. So if the patient faints, observe and provide supportive care until the patient is recovered. Try to help them to the floor if you can. And by all means, in all circumstances, if possible, support the head. Now, before it makes contact with the floor. The last thing you want to do is see a patient drop and see their head bounce against the floor. Never seen it. Don't want to see it. I have had patients pass out on me. You just try to do your best to help that patient to the floor safely. If you have assistance, of course, that's always helpful. You may be on your own. But if that happens, they hit the floor, you want to make sure they're very, they land as gently as possible and get help as soon as possible. And by the way, follow the protocol that your clinic has instructed you to do in these types of situations. Always follow protocol. Oh, we shifted off center for a little bit. Let me realign this for you. Give me just a moment here. This slide was way off to the side. I didn't expect that. We're just going to expand this viewing area over like that. There we go. Tips for minimizing pain. Let's get rid of these lines here. Let the alcohol used to clean the site dry thoroughly before you inject. Have the patient relax the muscles in that injection area, so have them shake their arm out. Starting a very casual conversation at this point is also good too. For elderly folks talking about their grandkids or vacations or anything like that, their own children, anything to distract them for a moment while you're doing your work can be helpful. Quick penetration with the needle through the skin, smooth, continuous darting motion. I highly recommend that. Inject medication slowly and steadily. I highly recommend that. And never change the direction of the needle during insertion or removal. It should go straight in and come straight back out without any exceptions. And I was afraid that would happen. The slide shifted back over, so we're going to realign it. There we are. Possible side effects. So with IM injections, it's the same with anything else. We can have reactions. Most facilities will have you wait 10 to 15 minutes after injection for signs of a drug reaction, especially on the initial time the person gets it. So let's say you're doing a Hep B series and it's number 1. The first injection, they're probably going to have you wait for 10 or 15 minutes. If you have no reaction, you may not be required to do that for the second and third injections. Once again, facility specific, so do what your protocol states. Possible side effects are minor discomfort at the injection site, soreness, localized redness, swelling, or bleeding at the injection site. And if it's an immunization, they may get a low-grade fever, which actually isn't a fever. It might be what I would call more of an elevated temperature, somewhere between 99.9 and you'd say 100.1 or 2. A fever really isn't noted until you get over 100.4, and then we call it a febrile state. So anything below 100.4 is not technically a fever. So a low-grade fever may present, and like I said, that's usually with immunizations. Just a moment here, my slide is stuck. There we go. Adverse reactions and complications. So adverse reactions are undesirable reactions that occur after vaccination, and these can be more severe. So it could be a drug allergy, which could trigger anaphylaxis. Once again, these are more extreme complications. You won't see these very often, if at all. Excessive pain, burning, numbness, fever, rash around the injection site, infection at the injection site, continued bleeding in injection site, medication is injected into the wrong area. All of these are possible emergent situations. So let your doctor know, let the supervisor know. You may get an order to call 911. If you're working in a clinic, I would never call 911 unless you're directed to do so. Many times they want to have someone else intervene and make sure that an ambulance is actually needed before you call 911. Once again, follow the protocols at your facility. Documentation, I'm going to let you read this over on your own. We've talked a lot about documentation. You've practiced some of it, so you already have an idea of what's required of you, and it doesn't change much just because we're doing an IM injection. So these things all need to be recorded in the chart. Here's a charting example of how we would do an IM injection. This is for Hep B. So do note this, and you'll be practicing this in lab. To prepare for the injection, once again, I'll let you read this over. It's really no different than the preparation we did for sub-Q. What changes is the type of medication, and what changes is the size of the needle that we're going to be using. Otherwise, when you're doing sub-Q or IMs, they're almost the same. It changes when you go to use your needle selection. And the other great differential on these is, of course, the sites that you've been going at. So sub-Q is obviously different than IM, and you're quite aware of those differences now. So that's really the only difference when it comes to these types of injections. When it comes to equipment, pretty much the same thing. As I said, needle size is what's going to be your biggest variation. In preparation, this is for all injections. It's really for all medical procedures, period. You should be following these steps every time you lay hands on a patient, in terms of sanitizing hands, getting your equipment together, drawing up the medication, identifying. Most of these things are standard medical procedures, so just have them in your routine. Some of these items, of course, are specific to injections, and they are good advice, so I definitely would follow them. When it comes to the IM injection administration, once again, not much different than the sub-Q procedures we go through. Routes and how we actually enter the tissue is a little bit different, and we'll discuss the subtleties of this in our lab section. And this is just some more IM injection administration information, so very good to read and understand and know about, and we will go through these protocols in our lab section. And that's the end of our lecture. So that's everything you need to know about IMs before you come in and do them. So I hope you enjoyed the lecture. Hope you got some good information. Hope you took some notes. Get busy on that homework. Get that off to me. Once again, this week we'll be bringing our assignments to the lab section as opposed to posting them on Canvas to make it easier for everyone involved. So make sure you complete that homework, or I should say print it out, complete it, and bring it to me on Monday in lab. Hope you're all having a great day, and we'll look forward to doing some IM injections with you in just a few weeks. Thank you.